Good morning, everyone. Welcome. Welcome to the Behavioral Health Echo series. Thank you, all of you, for being here today. My name is Andrea, and I will be helping with facilitation today. For some of you who might be new to this series, the Center for Substance Use Training and Telementoring, CSTAT, a division of the Bayview, Texas Institute, created these behavioral health sessions with the intention of supporting you, the behavioral health professionals, with ideas and strategies to screen, intervene, and refer persons who use substances. We are offering today CEs, so please be on the lookout of that email right after this class. Once you complete that post-session survey, we should give it approximately 3 weeks and you should be receiving your certificates. So again, thank you for being here. Before we start with our didactic presentation, I want to remind all of you that this session is being recorded for later distribution. If you want to revisit the content of this class, we invite you to go to our Be Well Texas YouTube channel. There is a robust library of videos and trainings from all our 8 programs that we have been putting there for a long time. Please take advantage of that information. It's your opportunity to go, rewind that video, take notes, and really take in all the wealth of information that we share during these sessions. Also, if you know someone or coworkers who may not attend these classes, well, they can go to our Be Well Texas YouTube page and have access to the classes as well. So we're going to start with introductions. Clarissa Aguilar, could you introduce yourself to the group, please?
Hello, everyone. Thank you for joining. My name is Clarissa Aguilar. I am the Director of Psychology and Training at the Center for Healthcare Services, where we provide integrated primary care, mental health services, and substance use treatment services. Thank you.
Thank you. Didi.
Get ready to put my info into the box there. Good morning, I'm Didi Stout. I am an associate professor over at St. Mary's College in Moraga, California, where I'm in the graduate counseling and forensic psychology department. I have a private practice where I do work with people who use drugs in a harm reduction format. I also work with couples and families, have done so for a very long time, and I do trainings, mainly in motivational interviewing, harm reduction, and trauma-informed work.
Thank you,
I'm an
Didi.
author. I always forget my books. Sorry. Working on the second edition.
How can you forget that?
I know.
Yeah.
I'm a terrible marketer for myself with that. And I got to get better because we're working on the second edition.
Oh, good.
Thanks.
Thank you. All right. Polly, our case presenter of the day.
Hi, my name is Polly Cordova. I am a certified nurse and midwife at Pharmacological Health and Hospital System, and I'm also an addiction medicine provider here. Thank you for having me.
Thank you. It's a pleasure to have you with us. And Dr. Denis Antoine, you may introduce yourself and start with your didactics.
Thanks so much. I'll do the sharing of the screen first so I do not forget. And my name is Dr. Denis Antoine. I'm a psychiatrist by training, but I'm also certified in addiction medicine and coming to you from Baltimore, Maryland today, where I'm the director of the Addiction Treatment Services program that we have here on the screen, but also that encompasses the Center for Addiction and Pregnancy track, which I think will play a role in today's presentation. So looking forward to really hearing questions and talking through the case, but I'll jump into the presentation just so we can start off with some of the information there. So as the title says, I want to start talking about pharmacological strategies for substance use disorders. Overall, no disclosures, as the slide says, and I do want to get through a few objectives to examine the role of medications throughout this process of what we'll call recovery and how to integrate that together with the other services. Also give an overview of the current pharmacological treatments for substance use disorders, and still determine how we can individualize treatment and tailor the strategies to meet the persons where they are in recovery. And of course, we should probably make more room for the role of behavioral health providers on the care team, because they play a large role, as I think the case will also point out. So giving a background here, this is an old problem in terms of why we need to think about medications. And this quote is coming from 400 BC with Hippocrates, who talked about the description of a person being in the prime of their life and having trembling hands and thinking about what we need to do here. It really is what we call a prodrome, or the announcement of something bad is about to happen to this person, whether it's withdrawal, delirium tremens, something along those lines. It is the time to think about what do we need to do about this. And back then in 400 BC, there weren't that many options. So it was something that we couldn't do much more about. But as time advanced, there was more what we call medicalization of substance use disorder treatment. And this is Dr. Benjamin Rush, who was the first president of the American Psychiatric Association. And he was a champion at that time for a couple of things, which we've changed the terminology on. But in particular, he was a champion of using pharmacologic treatments for substance use disorders in order to help where possible. Back in the 1840s, when he was in place, we had probably little nuance to what we were doing. And there were different names like morphism and alcoholism. But his forefront goal was to make sure this was a medical treatment. So it gave a little more credence and to say, we need to take this seriously. It's not just a thing about will and morale. There's something underneath that we need to take seriously and make sure it's treated well in a proper manner. So moving forward, I use a slide that I'll spend some time on. We've now gotten to the approach where we've been a little bit more nuanced with what the pharmacology or what the drugs do to a person's system. And what we have here are 4 different scenarios. And I'll take some time to explain all of them, but the portion where it starts with letter A on the top left is one that I think we can think of as the baseline, as a person who's never used a drug before, no matter what the substance is. Talk about alcohol, opioids, cocaine. The person is naive, and whatever that substance may be, even tobacco to a certain degree, when they have that first use of the drug, we know that the pleasurable response, which is the up and down here on the graph, they will get a pleasurable response. And all the words on the graph don't matter as much, but they're really neurotransmitters that kick in when a person uses that substance. So there are things like dopamine, opioids, GABA, glutamate, and I can go over a long list of those, but it all comes down to the point that when a person uses that substance, their pleasurable response goes up when they're drug naive. And when the substance wears off over time, that response wears off and they might have a little bit of a dip, and hopefully they would come back to baseline and keep moving. So that's where we are with scenario A. Moving over to scenario B, that's when a person is more dependent. And you would see that after a while, they are still chasing that high. That's a common term that can come about when a person is still trying to get that high pleasurable response that they had in the first scenario A, but they need to use more and more just to get back to where they might get that initial high, but they're having a harder time getting back to that. And overall, what happens when that person stops using, if they're very much dependent, their dip is much, much lower than in scenario A. And some people now call that the anti-reward system because you're going in the opposite direction. And it's not worth necessarily going into detail of the neurotransmitters that are involved in that, but all to say there are a lot of those neurotransmitters, dopamine and opioids and GABA being some of the main ones that lead to a person feeling really bad when you're in that lower state. And so you want to avoid that dependency and that withdrawal in particular. That's that anti-reward state. And that goes back to Hippocrates' explanation and description back in 400 BC. You don't want to let a person go there, and you want to keep a person out of that hole. So in terms of withdrawal, that's where you see a person go to a medically supervised withdrawal program, inpatient service, getting through that phase, making sure you're not going into DTs or severe seizures or other things. And even for opioids and other substances, you'd want to make sure a person stays out of that space because it is unpleasant for them. Now, scenario C is a little bit more difficult to explain, but again, it's more when a person is still dependent but has had episodes of taking binges and staying away from substances for a while. So a little bit of back and forth. But you can see still a person has that difficulty getting back to the baseline. After a while, they're really just trying to come out of that hole, as a lot of patients and individuals try to tell me. And again, that anti-reward system is very deep. So the goal there is to say, how can we get a person out of that hole, keep them out of that hole? And sometimes you have to use pharmacologic agents on the inpatient side to get a person back to that baseline or avoid that withdrawal. You can't keep a person on that forever because they would become further dependent. But what we try to do when we're on the inpatient services is gradually taper a person off so they don't have that dip at the bottom and they don't have the withdrawal overall. And that can take a long time depending on how long a person has been using the substance and how long what we call is the half-life of the substance, how long it takes to clear out of the system. We try to use things that don't cause a roller coaster effect because some certain substances like nicotine, cocaine can be very short in their effect on a person. So they can bring up the pleasurable response, but then drop you down very fast as well. So in trying to avoid this withdrawal syndrome, that dip, we try to use longer acting medications. And I'll talk about some of those in a little bit. Now, one of the more controversial pieces, and this graph overall is from the head of NIH and NIAAA, the National Institute of Drug Abuse, and also the National Institute of Alcohol and Alcohol-related disorders. They put together this graph to show how a person traverses through their substance use. And the letter D is one that is probably one I focus on the most when it comes to clinicians and behavioral health providers. All to say, if a person has a long period of abstinence, theoretically, and I think this is where a debate could occur, you would see that their baseline of how they experience life and their pleasurable response ends up being lower over time. And that is something we can go over graphs, we can go over pictures. That's a difficulty where they might use substances again just to get back to where they were, but theoretically, even if they were without substances for a while, they might not have the same pleasurable response at baseline as they did before. And that's something to grapple with. It often end up being the question, how are you going to live the life that you want without the substances that gave you the pleasure before? And that could be a tough conversation to start out with, but it often ends up being one that you have to have at the beginning. Now, this is where substances can come into the picture. And this is also where medications can come into the picture. But something that's key to understand beneath all of that is how do these medications and substances work? They go to the receptors and they do one of three things in this case. Agonists are medications or substances that go to the receptor. And as it says on the left side, they activate that receptor and send signals to give that pleasurable response, give more of it. And full agonists, as we say, give more and more of that response and more of that activation, the more of it that you pour in there. So there's really an unlimited amount of response that can happen there. On the far right side is an antagonist. And what it does is it blocks that receptor from having any response at all. So it's almost like a cap. Once you put it on there and it fits very tight, nothing else can jump in there, or you need to pour a whole bunch of force to overcome that antagonist. So sometimes that can be good because it can protect a person, but you can imagine if there's an agonist on there already, and then you put this antagonist on there, you're going to force that person out of their pleasurable state and bring them down the roller coaster, and that's not going to feel good at all. So if anyone's ever been part of giving Narcan to a person who's overdosed, they're not a happy person when they wake up, even though they're doing better. It's because you brought them down that roller coaster. And that middle graph there really shows how you can have a back and forth of that agonist and antagonist effect. This graph is a little bit different, and it points out a couple of things. One, like I said, a full agonist, the more substances you have as you go to the right, the more effect and response you get. Antagonist is that zero flat line. You don't get any response at all. And then there's also partial agonist, which is the closest thing to buprenorphine in this case, where you add more and more to it, but there's a peak to the effect and response that you get. The most common one that we think about here would be buprenorphine, but varenicline, I won't use the trade names here, but varenicline for smoking also works in that same way for nicotine receptors where you just get a partial response. Inverse agonists we don't think of too often, but for those who are thinking about xylazine and clonidine, they tend to work that way as well in terms of working on the alpha-2 receptors. And won't have to go into the names, but they work by the more and more you use them, you get the reverse effect that you would want. You don't get that pleasurable response, but more so of a decreased response. But these are how the substances work, and the process becomes the same no matter what class of substance or drug you're using or thinking about. And in terms of pharmacologic agents for substance use disorders, we unfortunately are limited in what we have. And that's always been the struggle to say we have different things for different substances, but I can go through them in the next few minutes so you can have a good understanding, but then point out some of the limitations as well along the way. So tobacco, I think we have some options there. For the parenthetical statements, the parentheses there, I put a big A for nicotine because it's a full agonist. If you were to give a person more nicotine, you would feel more of a response, but it is a case that a person can have too much of that for nicotine replacement therapy. And I've seen people become psychotic, have abdominal pain, different side effects of nicotine intoxication unintentionally when they're trying to replace nicotine and vaping. So that's something to keep in mind there. Bupropion is another medication that's also an agonist because it works on some of the same receptors as nicotine downstream with the dopamine effect. So you could use that as well. And then varenicline, as I mentioned, is a partial agonist that gives a partial effect. So it's not always the easiest to use if a person's a heavy smoker, 2 packs a day or so. It's a little bit easier when a person is cut back because you're not bringing them down the roller coaster as far. Alcohol, similarly, in terms of that same antagonist effect or a partial agonist effect, which would be an encamprosate, which works on the GABA receptors partly there. And then there's naltrexone, which blocks the receptor. And one might think, those that know deeply about that pharmacology, well, alcohol is a GABA receptor, so why do you put something on the opioid receptor? Ultimately, all of these give a pleasurable response. And that pleasurable response is what naltrexone is trying to break off, if you will. So I tell the individuals that I work with, this is not necessarily going to stop your cravings. That's not what naltrexone is for. What it's for is to decrease the pleasurable response so that first drink doesn't lead to 10. And that's what the original studies showed there, that you're preventing a person from, as some of my the individuals I work with tell me, from going off to the races with their drinking. So you can have a chance to intervene more. Antabuse, disulfiram is the other name there, is one of the exceptions here where it is one of the medications of this list that causes a negative reaction to use of the substance, where a person ends up going into what we would really say a withdrawal and also physiologic issues, nausea, vomiting, sometimes hypertension, very negative reaction. And it can be used, but it really needs to be monitored very closely because certain household items can tee off that reaction as well, whether it's hand sanitizer or different things like mouthwash as well. For opioids, we're again back in that same train of using agonists or partial agonists or antagonists. Methadone as a medication is a full agonist, so the more of that you use, you can get more effects, and that can be good, but it also could be limiting in the sense that you might have to go higher than one would like given the interactions with other medications they're taking. And methadone has a long history of having other psychosocial requirements through the OTPs. That's probably a 2-hour lecture in and of itself to go through the limitations of how methadone is delivered. But pharmacologically, I think it could be something that could be helpful if a person needs something to compete with a heavy history of recent substance use. Buprenorphine, partial agonist, again, it needs to be very mindful of how much a person has been using recently because it could trigger that decline, that rapid decline on the curve, and what we call precipitated withdrawal. So you need to be careful with that and naltrexone if you're going to be using it for opioid use disorders. I always ask individuals, have you used recently in the past, probably even 2 weeks, because there can be protracted withdrawal and protracted amounts of individuals coming into the door, and they might not realize they've had opioids in their system or in their drug supply. So you need to ask and probably do a toxicology screen before you use that medication. And then for cocaine, there's some evidence to suggest that cocaine use disorder is helped by topiramate. And I say some evidence because there are studies that are for use of topiramate, but there are also some studies that are less in favor of that. So I think there needs to be more research as to whether topiramate is a long-term agent, and there could also be some other agents that could come along in the future. But unfortunately, cocaine has little, on here for use. And as you can see, there isn't anything right now for cannabis and other substances. But I think this is where the research needs to happen in the future. So I'm going to pause and just talk about a study that we did in Baltimore a few years ago, and it's going to also point out one of the limitations of using these substances and using these medications for substance use disorder. We did a study a long time ago where we had 23 people come in, part of a clinical trial, and they all had a similar history of substance use disorders. And to test and qualify for the trial, they had to receive, in random order, 30 milligrams of oxycodone or placebo, just sugar water on another day. And I do see a question there about amphetamines. I'll come back to that a little bit later for sure. So for this study in particular, and it actually does dovetail a little bit into the question there. We expected, we saw all the expected physiological responses to vital signs and things like pupil constriction, vital signs, and everything else. And that didn't vary at all beyond what we expected. What did shift and what was surprising is that 39% of those individuals couldn't tell the difference between the 30 milligrams of oxycodone and placebo. And that was a bit unexpected there. And the people that had that inability to detect the difference liked the placebo more than they liked the oxycodone. So those were surprising things, all to say that we often think we know how a person is supposed to respond subjectively in that pleasurable response to these substances, but we don't really know all the reasons why just yet. It's not just about the pharmacology. It's not just about the drug itself. There are a lot of other factors that I think should be explored and will be explored over time. One piece is precision medicine, and that has to do with the genetics of the response. Some things people are looking at now are whether we have different types of genes that code how we respond to these things. And it's almost similar to people who have an aversion to cilantro. My mother has that, and that's a genetic thing where 10% of the world hates cilantro, whereas I love it. And there could be the same thing for substances. We're starting to see that data come out now that people might respond differently to those substances and also respond differently to the medication for those. But we need to do more research about the individual variability about that, because we might just assume that the same treatment will work for everybody else. Beyond that individualization on the drug itself, I think there's a different way of looking at the perspectives of what a person is going through. And this is a snapshot for what we typically do in Baltimore at Johns Hopkins, and looking at different dimensions. I don't think this is by all means or any means the only way of looking at it, but it's usually for me a shortcut of thinking about different things a person is going through. And hopefully I think our case will look at this in different ways. In short, it looks at what a person has in terms of any processes, medical processes, and tries to cure those. It looks at who a person is in different ways, whether it could be educational barriers, social determinants of health, also any IQ cognitive limitations, things that are measurable, and tries to make sure that we account for those and guide and figure out ways to strengthen those issues. And then behaviorally, beyond just substance use disorders, it looks at any types of antecedents or any things in their environment that might lead to a behavior that has negative consequences that has gone on over and over time. That's been a difficulty to break, and looks at different ways of challenging those behaviors, whether it's motivational interviewing, other therapies, other counseling, to find a different way of transforming those behaviors into something more positive. And then with the life story piece, we can't forget a person's background, their setting, and how that leads to different outcomes depending on the sequence. And that's where things like trauma, different experience that might be individual to that person should be brought up and discussed, so that you can hopefully reskirt that and lead to a better life over time. So again, this is a snapshot of what we do, and there are many ways of thinking about it, but it all points out that we need to individualize how we discuss the person. And with treatment planning, you need to bring all of that into the treatment plan. It's not just about how much they used over the past few days. We've been coached here, actually just finished our Joint Commission survey about 1 hour ago, oddly enough. And one thing they're saying now with their treatment plans is that we need to make sure we talk about strengths and needs. And also, as you see on the right side, social determinants of health. All those things need to be brought into the treatment planning process to make sure we're accounting for who the person is, who their context is, and all of those portions of the wheel, their education access, their healthcare access, economic stability, neighborhood and built environment, and also the social context. So I think we will be getting to a point, because I also am on the CARF side, where persons will need to bring these elements of treatment planning into the actual documents of our treatment plans to make sure that's done. Beyond that, it's going to be important to make sure that we have different ways of dealing with that, not just the medication. I always tell the folks I work with, it's never just about the medication, never just about the drug. You have to think about other ways of doing it, whether it's therapy, counseling. Social support has always been shown to be the largest predictor of long-term success as well. So that's something that needs to be championed in the treatment plans as they go forward. And it becomes a question then of, how do we fit in, behavioral health providers in this whole process? There's a lot to think about. And when we're thinking about the medication, it really sometimes casts a shadow of how can other folks play a role. And I know we have a wide array of practitioners on this call. So I always think about, going back to that circle, how can we bring everyone together to have a discussion about all these different aspects of the individual, whether it's the pharmacist who comes into rounds, as we do here, having that conversation, or it's the peer navigator who talks about the social and community context. There first needs to be probably a standardized and routinized way of having those conversations. And when approaching with the individual who's coming in for help, making sure there's an assessment and a way of asking, are you having your needs met along the way? Because that could allow you to build that rapport, have that conversation about things that might be more sensitive, but open the door to say, oh, well, this might be a barrier to this person advancing along the way. But I would say that making them aware that medication can play a role could be part of that conversation with whomever has that closest rapport with the individual, but always to say, it's not the only thing that's part of the treatment plan. There are other things that we need to think about, but if medication could be helpful, we want to give you the best possible care that we have. And that's probably the best stance done by a whole team rather than just one individual. So I would say behavioral health providers have an opportunity to talk about meds, also tie into other experts who might have a deeper knowledge to individualize how those medications could be used as well. But overall, if we're looking at the whole picture, I think that's going to get the person where they need to be. So I'll stop there. Like I said, I'm looking forward to the questions and also the case presentation. I'll say earlier to the question about methamphetamines, what I tried to put in the slides here were medications that were FDA approved for the substance use disorder. My recognition in the field is that we don't want to bring people down the roller coaster fast. So you would never tell a person who comes into the door for the first day, stop your alcohol right now, tomorrow. That just wouldn't work out. So I think there is judiciousness, if you will, of how you approach a person cutting back. But I tried to focus on the medications that are FDA approved in this talk, but I think we could definitely talk further about harm reduction strategies that could be helpful as well. And
Thank you.
Yeah, go ahead. Yeah.
No, thank you. I was going to
Yeah.
say great presentation. I was going to open the floor for questions, but please go ahead, Dr. Antoine.
So I'm seeing one question about baclofen for alcohol use disorder as well, and it's kind of that same vein. How do I explain this? Baclofen is a tough one because it works on the cousin receptor for alcohol. So it has some crossover, but not always the best. But it in a pinch it could work, but it's actually a little bit more potent than some of the other medications. So the withdrawal I've seen is a bit more potent. So typically the Libriums and the longer acting benzodiazepines work a little bit softer than the baclofen, but it could work.
Yeah. Questions, comments from our learners?
So I'm seeing a question here, mentioned cannabis, and some of our meth users call it an exit drug. Yeah, so we've done some research here on the campus that shows again that everything goes towards the opioid receptor, including cannabis. So the first thought would be cannabis works on the cannabinoid receptors, but we are finding more and more, and it's not surprising since there is evidence, obviously, that cannabis works with pain a lot of the time, that there can be some overlap with the opioid receptor. So I could see why there would be evidence as to why this would be an exit drug. It's not as potent necessarily as the classic opioids, but I could understand why some people take that and would use that as an quote exit drug.
We have another question. Someone is asking about withdrawal medications for methamphetamines.
That's one of those areas where when I'm talking to the folks on the West Coast, because I'll admit in Baltimore, methamphetamine is probably in the 5% or less of what usually presents. But typically, it would be something where it's the behavioral aspect of the methamphetamines that are most difficult. So we, in the psychiatric realm, we would think more about things to decrease the psychoses, make sure those are more comfortable coming downward, and have more supportive care. Nothing federally approved at this time, but the harm reduction strategies, I think, would be best to make sure that there's a gradual decrease in that use. But unfortunately, from a FDA officially approved side, we don't have anything yet at this time.
Thank you. And here someone says, meth use seems to be most of our recovery folks use at this time. Hopefully something on the horizon for now, since we're practicing harm reduction.
Yeah, I agree with that. We actually had studies before, and you can imagine things like vaccines have been tried before, and there are limitations to all the different pieces because these receptors and these neurotransmitters that are being stimulated affect a lot of things. So if you were to block that receptor that is affected by methamphetamine, you'd also be blocking the function for a lot of different parts of your body. So you don't want to necessarily do that. So that's part of the difficulty of fine tuning this process to say, how do we just get the substance use that's difficult or illicit, if you will, without blocking the ones that stop your heartbeat.
And one last question. What can you say about ketamine being used to help persons who are in the process of recovery?
There's a lot of work there. I'm 3 floors above the Center for Psychedelic Consciousness Research in Baltimore, and ketamine along with psilocybin are getting a lot of attention right now, which I think we need to get more evidence on. I think there's an opportunity there. What they've said, can you still give me one second?
Yes.
Can you still hear me?
Yes, I can hear you.
Okay, now I can hear myself.
If you
again. Sorry
raise your volume a little, probably we will hear better.
Is that better?
Yeah.
Okay,
Perfect. Thank you.
Sounds good.
Yes.
What I was going to say is what they're saying is very key towards the experience is having what is called a near-death experience. So ketamine and psilocybin create that to a certain degree, and that near-death experience can be manufactured, if you will, and then guided through with a guide that has that close relationship with the person going through the experience. So I think ketamine and psilocybin can do that, but one could also say, how can you recreate that with having to use psilocybin or ketamine? Does therapy do that? And if people have gone through traumatic experiences or might end up in the hospital, is that a time also to intervene there? So I'll go back to my old statement. It's not just about the substance. It's not just about the ketamine and the psilocybin either, but the experiences that they're describing in that consciousness work, I think will be very helpful and very important to use to get through these types of experiences.
Thank you. And before we move to the next part of our session, if you could briefly comment on The transition from methadone to buprenorphine, Dr. Lubner is asking.
Absolutely. So I would say it's similar to that ride, if you will. As I mentioned with buprenorphine, you could bring a person down from a full agonist to to that partial agonist. And we did this with the individual last week and worked out well. So what we try to do with the methadone first is bring them down to a point where you can maybe spend a day or two without the methadone and not get too many symptoms. And so what happens there, we got a person down to about 20 to 30 milligrams. And actually, Dr. Van King, who's down in Texas, taught me this method, and it's worked out fairly well. After about 20 to 30 milligrams, we say, let's stop your methadone for 2 days. And when you come back in, tell us what your COW score is. That's an opioid withdrawal score. If there's a little bit of withdrawal, that's a good time to start the buprenorphine for, we started at about 2 milligrams, did a test dose, waited for an hour, then we went up to another 4 milligrams, and now he's actually at 8 milligrams once daily and doing quite well. I just saw him this morning. So that way has worked well, and that's kind of the way microdosing has worked out. We wrote a paper here a few years ago also doing that for fentanyl. If person are using fentanyl or chronically, same thing. You wait for about a day in that case, and then you try the buprenorphine in small doses with the microdosing. But microdosing in those situations, when a person is assuredly have a little bit of withdrawal, seems to work out best.
Thank you, Dr. Antoine. Definitely a topic that we can bring again as a second part to another session. But in the interest of time, we're going to be moving to our announcements. And the Center for Substance Use Training and Implementing CSTAT provides a wide range of needs a wide range of solutions for your needs. And technical assistance can be anything from clinical mentorship, contact or linkages to organizations or resources in the community, or maybe ways to distribute or obtain medications for opioid use disorders. So whatever your technical assistance need is, please go to our CSTAT website. We're sharing that on our chat box right now. There is a TA form. Once you complete that form, someone from our team at CSTAT will get back to you in around 3 days. So please take advantage and use this resource that CSTAT is offering you. Next, please. And we're always looking for case presenters because we believe that learning is best served when it happens in real time and with real cases. So this is the perfect forum for you to bring any case that you or your organization are currently managing or managed in the past. Presenting case with us, I call it a win-win situation. You get help from our experts and from the community, and our learners also take advantage and use that information to help themselves as well. If you want to present a case for us, please send us an email at cstat@utesca.edu. Next. And BWell Texas is still recruiting volunteers for this study. This is an incredible study. What we need is persons who are currently enrolled in buprenorphine treatment, over 18 years old. Their participation is compensated, and it's a great way for persons who use substance to learn to self-manage their use through this incredible app. So if you need information or if you know of someone who would like to participate in this study here at BWell Texas, please contact Jessica, and we are sharing her email and phone number. She's here at BWell Texas. Next. Our next session for the webinar, Thriving in Substance Use Disorder in the Post-COVID Era, we're going to have Dr. Mackert discussing communicating during a public health emergency. If you want to register for June 18, please go to cstat.utesca.edu/COVID-19. Next. And next month in the same space, we're going to have Dr. Aguilar talking about interdisciplinary team-based care in substance use disorders. That is Friday, June the 28th To register, again, go to our CSTAT website and you can register there. Remember, when you register, you will receive an email, and through that email, you should be able to enter to our Zoom session. We will see you next month on June 28th. Thank you. And now I think we're ready to move to our case presentation. And very briefly, I want to thank our case presenter, Paulie Cordova, for presenting this case with us. A quick reminder to all of us that we always discuss our cases. We can be as detailed as we want and aspects that are relevant to the case itself, but we should not share any information that is too particular or too specific to the person we are discussing. There are PHI regulations that we all should follow, so please know places, names, locations, addresses, etc., to protect the identity of the person we're discussing. But with that, Paulie, whenever you're ready, if you can briefly walk us through this case. Thank you. We cannot hear you, Paulie. Can you unmute yourself?
Yes.
Thank
Can you
you.
hear me now? Okay,
Yes,
thank
I
you,
can hear
Andrea.
you.
And whenever trying to come up with an appropriate case for this echo, this particular patient came to mind. She does not have a diagnosis related to her psychiatric stuff. She's not on any psychiatric medications, but she does have some very unique circumstances. The question that I would like to pose to the group is, where did it go? Is there anything that we could have done to help her be more interested in learning to read, write, and tell time, and write something more than just her name? That may not be the best question to ask because it brings bias to the table, saying that that's what the expectation would be from me. And so I think that the question more that I have is, what could we have done to continue to get her involved and stay involved in her healthcare so that she can continue to achieve her goals? So she is a 32-year-old female. She's brand new postpartum, and she does have custody of her baby. She has an extensive background in trauma. She identifies as being raised as a gypsy. She no longer leads a gypsy lifestyle, but her family moved her around frequently whenever she was a child, and so she never was enrolled in school. And because they moved frequently, she was flying under the radar for not being in school. Now that she's 32, she is having her second baby. The first baby was born premature. She was active in her addiction at that time, was unaware that she was pregnant, and went to the bathroom and the baby came out in the toilet. That baby was adopted, but she does have the ability to see the child twice a year. And she's still with the father of that baby. She has an extensive history of prostitution. She was molested as a child. She got into substance use. Her first use of anything was when she was 9 years old. And with the second pregnancy, whenever she got pregnant, she immediately came to the hospital saying that she was invested in getting into recovery. She had tried some other residential programs in the past, but had returned to use. Now she's got this baby and is super excited to try to be a good mom. And her goal, she said, quote, "I want to stay clean and be a good mother and be a good role model for her." So our goal is to try to help her achieve that goal. We've had her in the hospital for a bit, got her on buprenorphine. Transportation, like with many of our patients, is a bit of a challenge, but she did come to pretty much every prenatal appointment. And then postpartum, when we were following her, trying to get her connected with community resources for her wide variety of needs, she came to every one of those appointments as well. The father of the baby brought her to most of those appointments. He was very engaged and supportive of her sobriety, and he was really excited to be able to parent the little girl. So As far as the client's strengths and resources, she really does have a strong desire to improve her health, take good care of the baby, and meet all the requirements of CPS so that the father of the baby can continue to live with them. The house that they lived in by themselves was in an unsafe area, and so the patient decided that that's not where she wanted to take her baby back. She made reference to the sounds of gunshots in the neighborhood, and so she moved with the baby to a family member's house where everybody is sober, and it was a safe place for her to be. And CPS also really approved of that. But then the father of the baby was still smoking marijuana on a regular basis. And so he quit smoking and has met all the requirements that CPS has set forth. And so now he is able to join the family in the safer environment. The strategies and interventions that we tried for her were pretty significant, and the person who was the most integral in her care was our peer navigator. Stephanie Morillos is on this call with me, and she is our peer navigator. She was critically important in the care of this woman and offered to help her to start the program, to start a program to further her education, to learn to read and to learn to write, tell time, and manage money. But the patient declined. She had no interest in becoming educated. She wants to do a good job, but she doesn't want to pursue her education. So by using shared decision-making, the peer navigator helped her to work to make a virtual intake appointment so that she could continue to get her buprenorphine. Because she couldn't read, she couldn't read the instructions about how to attend that virtual visit and make that connection. And so by holding her hand through the process, we did an excellent job of a warm handoff so that she felt comfortable continuing to do virtual visits to be able to continue to get her medication. She also has hepatitis C, and we connected her with our hepatitis C clinic within our hospital system. And she is now on medication to treat her hepatitis, and we were able to get it for her at no cost to her. Unfortunately, she has a very significant mass of genital warts. At one point, we were concerned that it might even be obstructive for a vaginal delivery. However, she did deliver vaginally. Unfortunately, she did not get funding approved to have laser surgery, and so that particular piece of her health has fallen through the cracks. When she would come to her postpartum appointment visits to get refills on her buprenorphine, she brought the baby with her to those appointments, and we were able to observe her caring for the child and then give her pointers on how to maybe wrap the baby a little bit more securely. And she did an excellent job of changing diapers and mixing the formula and feeding the baby, all of those kinds of things. And so it was a great opportunity to give her positive accolades for being involved in her baby's care and doing such a great job of parenting. You can see here on her list of drug use that it's pretty extensive. She started smoking when she was 9. She had her first alcohol when she was 9. She still smokes cigarettes. Her primary drug of choice, though, was heroin. Can you scroll down? As I had mentioned, she's still involved with the substance use counseling, and our peer navigator was a significant part of that. She's been in residential treatment 4 or 5 times in the past, and now is successfully living on her own. I'm not really sure what a mutual aid is, and so our peer navigator knew what that was, and she said that we don't have that. She's been only on buprenorphine, never has been on methadone, and she does not have alcohol use disorder. She denies having any psychiatric history, but given the extensive trauma of her past, I can tell you that she is not without her own sensitivities. PTSD would be something that I would probably say is part of her past has resulted in some PTSD. And so in the end, I feel like we have a pretty good success story, but I do worry about her in her ability to continue to care for herself, given the fact that she can't read or write and therefore has such limited opportunities to continue in the path that she wants to go down. I'd be happy to open it up for questions.
Thank you, Polly. Yes, we would like to hear questions or comments from our participants and Hub. Yes, Didi.
Thanks for all of that, Polly. It is definitely an interesting and complicated case that you all have been working on. I have a lot of questions, but I thought I would start first with, if you don't mind, mutual aid is what we used to call, it's like 12-step. So we're changing the phrase from thinking as individual support, self-support, because it's not really self-support, right? I'm going to 12-step in order to have a group, a community of people to help support me. So we're mutually supporting each other. Right. So it's just a different way of using that language and wanting to change it. Right. So it's not really self-support.
We did give her information about how to connect virtually to various types of support. Stephanie, do you know if she ever participated in those?
No, and her reasoning was that she was connected to aftercare services at the treatment facility that she did residential at. So she felt between their support there and then my support that she felt like she was pretty covered, in addition to working with new connections. So she felt pretty covered in that area.
Yeah. And, that's what we always want to go for, is what anyone is interested
Yes.
in doing.
Absolutely.
Yes. Right.
Yeah,
and go ahead.
I was going to say, one of the things that we typically run into is, them thinking that they have to do 12-step. And of course, my primary job is to kind of like throw out options and, kind of meet them where they're at and see what's going to work for them. And so, I say, okay, cool. You don't want 12 steps. So let's kind of take a look at what you've got going on. And here are some ideas. And then we kind of get to mold it,
Perfect.
based off of what they want and need.
Yeah, that's great, Stephanie. That's exactly right. And so, Polly, you also had another question about how to keep her motivated, or to get her motivated, if you will. And so, in sort of an am I frame here, ask her. I mean, seriously, and I don't mean to come across as sort of a smart aleck with that, but seriously, just ask the client. So say, I'm really curious. You're saying you want to be a great mother to this child, and I can see that that's important to you. You're coming to all your visits. All of that is terrific. And I'm really curious about what would keep you motivated. And what about things like furthering your education? Seems like you're a little nervous about that. Tell me more about that. So just trying to engage her in conversation would be probably the best way to do that, and see really what the points of tension are for her around that.
So Didi, it sounds for what you're saying that this is more about first building rapport with this person and connecting with this person first.
Yeah, it's always about first building rapport, particularly with cases like this. When we were talking earlier, I said, that sometimes that's all I'm doing with a client. Honestly, I mean, not all, but that's the majority of the time I'm spending with someone, is just to build rapport. With people with trauma, it can take years to build enough rapport to where you can really connect with them well enough to actually get somewhere, if you will. And that's just the way it is. For some folks with this level of trauma, you may never get there. And I think that's managing our own anxiety as clinicians. Don't take it personally. Now, that is their way of protecting themselves. And actually, that's a healthy behavior, that they're now protecting themselves. So I sometimes acknowledge that right up front with clients and say, good for you. You know, you shouldn't be telling me everything. You should not be trusting me just because of my position or the letters past my name or whatever it is. You know, trust takes time.
Yeah, we were fortunate to be able to provide her prenatal care from, I think she was 7 weeks when she presented. And all of that trauma was not revealed until her first postpartum mat visit. And then we put a bunch of pieces together about her background. And then we were able to continue following her and still reach out every now and again to make sure that she's okay.
Yeah. Yeah. That's typical. Yeah. Who wants to talk about that?
Yep.
Right.
And I know we're getting close to time, but I echoed the other question that was in the chat about, was there any reason for not wanting to go with the educational services? My guess is that it may tie into some of the other pieces about trauma or other aspects coming through, but if anyone had information there.
I'll take that one, Polly.
Okay.
So yeah, we've had a few conversations about it, you know, when those resources were offered. Honestly, for her right now, it's just not important to her. You know, her main focus right now is maintaining her sobriety and being a good mom to this baby. And yes, while she's had another child, she's never had an opportunity to parent. And so this is something that she's really excited about and really wants to focus on. So you know, that's kind of it for her right now. It could change in the future, you know, like Polly said, you know, we're still keeping in touch with her. I talk to her pretty regularly, actually. And so, you know, if later down the line, you know, she's interested, then that's something that we could definitely, you know, continue to get her connected with. It might show up as the child gets older, you know, just child going to school and having that stable life that she didn't have, and you know, her wanting to help her child, like it could be something that comes from that, but for now it's definitely not a priority for her.
Yeah, that's great. And the last thing I'll just throw in, because Christine, you've been patient with your hand up there, is a lot of times people are resistant, particularly to 12-step, because there's a lot of misinformation about how particularly AA feels about medications. AA does not have anything against medications, and there's a great pamphlet about that. It's NA that has the problem with medications. So just FYI, you can check the pamphlet is called the AA member medications and other drugs and other medications, I think. But if you just Google it in, it will pop right up, and it's been revised in the last handful of years.
Thank you. Christine, did you want to say something?
Yes, and real quick, I'll be brief. I recently came across a client that also has a third grade education, or not looking at furthering her education, but I wouldn't limit to what they're capable of learning or know, because as you know, we know that 2-year-olds can identify McDonald's just by looking at signs, and now you type in anything into a cell phone and it can give you any information. It's just translating in the understanding. You mentioned that her child is an important thing to her, and she wants to be a good mother. As a coach, I would probably try to, if I had funding or resources, I would reach out to them and try to get some child storybooks that she might enjoy to read to her child. It's something I used to do with my son. You know, by the time he was in 3rd grade, he was reading all the Harry Potters, and he was reading to me. But it's bonding, and it's, you know, with one another, and it may make her want to change her mind and want to pursue that education. It's just how you introduce it to them, and she may be open to this little storybooks, you know, for the future for her child, and she may just pick them up and decide, hey, you know what, this is important to me, right? And just a way to incorporate the learning aspect of it, and make, you know, because I hear that her child is, you know, she wants to be a good mother and she wants to be supportive and, you know, be there for her child, and education is one of them, right? And so maybe start out with something that she's capable of reading, and maybe one day be reading to her child.
That's a great
Thank
idea.
you.
Thank you.
Thank you. Dr. Antoine, if you could briefly give us, in this very little time we have left, a quick summary of the case, some recommendations, and if we could somehow connect it to our didactics.
Yeah, I think that last comment is a good segue into that. What I heard was the word bonding, but also just attachment to the rest of the treatment team group. I heard that there was a great connection with this individual that led them to be able to engage in the treatment. And despite the difficulties and the challenges that have come through, whether it's trauma, substance use, and also the educational challenges, there's been an opportunity here to look at not only the individual, but also the dyad of the baby and the mother, and then figure out how we can move that forward. And that's the key here. The team approach, I think, has been very helpful. And there are opportunities to fine tune different things, whether it's through education, but also within what we were looking at, there's an opportunity to even think about how to fine tune the substance use disorder treatment. If there's still ongoing substance use, there's an opportunity, I would say, for maybe things like methadone or higher potency medications to help with the substance use. But there's also that opportunity to think about counseling and therapy to figure out what are the gaps and the barriers that aren't being addressed that might make it harder to achieve abstinence if that is their goal. But overall, I think this is the beginning of the conversation. And without more meetings and more people like Stephanie and other patient navigators or midwives and nurses and people who are very well invested in the care, this connection will not occur, and we would probably lose this individual in the direction that we would not want. So it's good to hear that so many folks are working on this, and hopefully we got more options and more ideas on the table to help out.
Well, we want to thank you, all of you, once again for taking part of this session. We want to see you next month. Remember, please, to answer that post-session survey so you can receive your certificates. And to all of you, have a great rest of your day. Thank you. Bye.